Hello, this is my demonstration of a PAT or Pediatric Assessment Triangle. We use the PAT in a pre-hospital setting to determine how sick a child is and how severe that sickness is in our initial assessment. So the benefits are it's hands off, so you can do this assessment while the child is in bed, in their cot or with their parents. It allows us to determine the necessity of early intervention. So before doing our PAT, Pediatric Assessment Triangle, running through all parts of that, we still need to consider our general impression of the child themselves and the household. So particularly in pediatrics in the pre-hospital setting, we get a good idea of the parents, their disposition, and the household if there's any signs of neglect or abuse. That is very important still. So the first part of the Pediatric Assessment Triangle that we may be looking at is the overall appearance of the child. So initially on scene, what we might be looking for in a child or a baby is the skin. So whether it's the texture of the skin as well as the color, in particular around the mouth, in the fingertips, any bluing or signs of cyanosis. We might all be looking for discoloration, so mottled skin, or signs of jaundice, so yellowing of the face or within the eyes. We're also going to look at the interactiveness of the child and the parent or the caregiver. So if they are responsive to their little, verbal or touch stimulus, how consolable they are. So if the child is crying inconsolably, you might also ask the parents if the child is generally consolable at this time, or whether they're teething or anything, other factors regarding that. If they've got an abnormal look or stare. So initially when you walk into the room, depending on the age of the child, you're going to look and see if they follow you in, if they can fixate on you, or you might be looking for signs of an absent stare or gaze into the distance, and they're not reactive to stimulus. We're also going to listen to the sounds of the cry, to speech if they are of talking age, if there's anything unusual about that. If they're sticking up, if they've got good muscle tone. A concerned thing we might be looking for in appearance is if the child is sort of weak and limp. So the next part of our assessment will be looking at the breathing of the child. So what we're going to be looking for is signs of difficult or laboured breathing that may come in the form of tracheal tug, positioning. So if an older child may put themselves in a tripod position. We're also going to be listening for sounds of upper and lower airway obstruction. So wheeze, stridor, like high-pitched noises, bronchi, and we may be using in our primary assessment the stethoscope to build more on that understanding of how they're breathing or why they have that difficulty. The third thing we'll be looking for is circulation. So we might look for things like mottled skin. Mottled skin in a warm child can be normal, but can also indicate abnormal blood vessel tone. We're also going to have another look for cyanosis, not just in the face, but in the fingers and toes. We're going to look for pallor. So generally, if the child is particularly pale, feel for that cap refill, which we want under 2 seconds. And of course, our heart rate and blood pressure, which might be carried out in our primary survey, keeping in mind that for pediatrics, there is a bit of a variation in heart rates, often quite a bit higher. So once we have assessed the appearance, breathing and circulation of this child, we can develop a good idea of their stability. So normal responsiveness in all 3 categories may indicate that the child is fairly stable. From here we can move on to our primary survey and get a bit more history taking, move on with our full assessment. If we've got poor results in all 3 categories, this is a good indicator of severe cardiorespiratory distress. From here, we might consider a really initial treatment, rapid transport, and moving on so we can treat that child best we can.